All right. Excuse me. We're going to call the meeting to order and ask you all to rise and please join with me with our Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Thank you. Dee, would you please take the roll?
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee.
Present.
Director Epen.
Present.
Director Stewart.
Present.
Thank you. Welcome to the October 14th, 2020 regular meeting of the Washington Hospital Healthcare District Board of Directors. To comply with Alameda County's order number 20-14C as revised on August 20, 2020 to slow the spread of COVID-19 and reduce the rate of transmission by sheltering at home and continued social distancing, this meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's executive order N-29-20 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concern not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak speak at this meeting? Hearing none, we will continue with the agenda. We will now move to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve the consent calendar items A through H?
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A through H.
Second.
Thank you. Dee, would you please take the vote, please?
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Epen.
Aye.
Director Stewart.
Muted.
Bernie, you're muted.
I'm sorry. Aye.
Okay, the motion is approved. All right, we're going to move on to the communications section. Are there any oral communications? Next, Dee, are there any?
There are none.
Okay.
There are none.
No written communications. Okay.
No.
All right. We're going to go through the presentations and Kimberly, why don't you discuss what's going on with the agenda with that?
Yeah, so I just want to let the board know that
We are going to be postponing the discussion and approval of the fiscal year financial audit to October 28th. So as the auditors are still completing their work, so this presentation will be postponed, and also the action item will also be moved to the October 28th meeting. So with that, though, we do have, are there any questions about that? All right, we do have a second presentation, and that is our community needs assessment. And we have Angus Cochran and Lucy Hernandez, and I will give their bios, but they are here this evening to present the community needs assessment that, as you know, every 3 years Washington does. It is not something that if we are required, but it's an important part of our mission and looking at what the needs of the community are. So to begin with, I'm going to introduce Angus Cochran. Angus has been with Washington Hospital since 2006 and currently serves as the Chief of Community Support Services. In this role, he is the liaison to the Service League and manages community outreach and the Health Insurance Information Service. He has worked in the healthcare philanthropy since 2000, first at the Advisory Board Company, a membership organization in Washington, D.C., and then at Sonoma Valley Hospital before coming to Washington. He earned a bachelor's degree from University of California in Los Angeles and a doctorate in English literature from Columbia University. Angus is a past president of the Niles Rotary Club of Fremont. I will also then, right now, introduce Lucy Hernandez. Lucy was born and raised in the Mission District of San Francisco. She has been with Washington Hospital since 2001. Currently, Lucy serves as the Community Outreach Manager, overseeing the hospital communities engagement programs and the Wellness Center. Previously, she worked in IT and managed the Health Resource Library. Lucy earned a Bachelor of Arts degree in History from Cal State Hayward and is also an alumna of Ohlone College. In 2014, she received her Master's of Public Administration from Golden State University. Lucy is very active in the community. She serves on the board of directors for Safe Alternatives of Violent Environment, the Newark Chamber of Commerce, and Avanzando, a nonprofit organization supporting Latinx students in Newark. Lucy is also a commissioner for Alameda County Commission on the Status of Women and is a past commissioner on the City of Hayward's Human Relations Commission. All right, I'm going to turn it over to Angus and Lucy.
Thanks so much, Kimberly. Thanks for that kind introduction, and thank you to the board for hosting us this evening to discuss the findings from the 2019-2020 Community Health Needs Assessment. Maybe the next page, please, Shri. So the hospital, just to give some background here, the hospital has been conducting the Community Health Needs Assessment for over 20 years. The Affordable Care Act mandated that all hospitals in the country continue to adopt an assessment every 3 years. And even though we're exempt from the ACA requirement, we have continued to do this every 3 years because it's the right thing to do. Next slide. The purpose of doing the assessment, of course, is to understand our community and the health needs that are there. We have a large district, as everyone knows, and this is a way for us to measure the health status of the community and to find out whether there might be disparities in healthcare and whether there may be pockets of these instances that we need to address. It allows us, obviously, it also allows us to develop programs to improve the health of the community through our health improvement plan develop after this. Next. One note on the data for this assessment. Between the last assessment in 2016 and 17 and the one we're conducting in the moment, obviously the ICD-9 code was dropped and the ICD-10 diagnosis codes were adopted. These are, as you can see from the chart here, the old diagnosis codes, there were 13,000 of them, and now there are about 68,000 ICD-10 codes. It makes it very difficult for us then to present longitudinal data for some of the diseases that we discuss in the assessment today because of this change. Next slide. So a quick note on how we went about doing the assessment. This is a collaborative effort between Washington Hospital and the 5 other East Bay hospitals that you see on the slide here. There were two types of, we engaged a third-party research organization, Actionable Insights, to collect the data and synthesize it for us. There were two types of data that they collected for us. One was quantitative data that we got from Alameda County Public Health Department, as well as the state of California and the U.S. Census information. And the second was qualitative data that we collected, focus groups with different social service partners in the district, and also with key informants who have a stake in healthcare, the provision of healthcare in the district. The quantitative data, because it came from a variety of different sources, you'll see different date ranges for this data. The data that we received, the most recent data collected from Alameda County, 2016, 2017, while some of the state data is a little newer than that, from 2017 to 18. But there is definitely still a lag between 2020 and the data that we were able to collect, the most recent data we were able to collect from these other sources. With that preamble, I'll turn it over to Lucy to dive into the details of the findings.
Okay, next slide. And thank you, Angus, for framing the history and process and methodology. Before jumping into the 2019-2020 Community Health Needs Assessment, let's first review the findings from the previous report and highlight a few key initiatives we accomplished through targeted programs and community partnerships. Next slide. We found asthma as a health need and learned through interviews the community is concerned about childhood asthma. To address this need, Washington Hospital partnered with UCSF Health to establish a pediatric asthma protocol to provide step-by-step guidance for evaluation and treatment. The hospital continued its partnership with UCSF Health to participate in the Pathways to Improve Pediatric Asthma Care study. This study showed the effectiveness of clinical pathways for improving quality of care with children with asthma. Next slide. In the previous report, we learned that community members did not recognize mental health disorder as a public health concern, whereas professionals saw an upward trend that behavioral health is a hidden disease. To address this, we increased community awareness through an education series with mental health experts and featured mental health topics on Bay Area Healthier Together and online TV programming with ABC7. The hospital partnered with the City of Fremont's Police Department and Human Services Department to help form the mobile evaluation team to respond to crisis call in the field. In partnership with Alameda County's board supervisors, Washington Hospital helped develop a 2-day mental health summit. However, it was delayed due to the pandemic, the COVID-19 pandemic. And the hospital also continued expanding its psychiatry and behavioral health program with psychiatrist Dr. Catalina Villa. Next slide. Cancer incident counts were also included in the previous report, and the trend remained the same from prior years. The hospital has a long history of cancer care programs which continue to expand during the reporting period. The hospital and UCSF Health developed the UCSF Washington Cancer Center to provide oncology patients with access to the latest cancer research, technology, and treatment options. The center was also approved by the Alliance for Clinical Trials in Oncology to begin a clinical research program. The hospital purchased the this tomosynthesis 3D mammography system to improve the ability to detect early breast cancer. And the board of directors also approved the purchase of the new linear accelerator for our radiation oncology center. Next slide. Heart disease and stroke were also identified as a community health need. To address this need, the hospital increased community education with online resources and provided stroke education directly into our community. The hospital continued our annual cardiovascular with the rapid imaging technology to quickly analyze CT and MRI scans of patients having acute stroke. The hospital also adopted a new acronym, life-saving acronym, BFAST, to remind community members of the common symptoms associated with stroke. The revised acronym now includes B for balance, E for eye, meaning impaired vision. And the hospital has been recognized with various awards for recognizing its commitment to ensuring the stroke patient receives its most care. Next slide. As regard to maternal and child health, we opened the prenatal diagnostic center with UCSF Health to provide comprehensive counseling and diagnostic testing to help women and their partners to make informed decisions. The World Health Organization and the United Nations Children's Fund awarded us with the Baby Friendly Hospital Initiative program. We also participated in an PRIME and improvement program, and we saw an increase in prenatal care, structured birth plans, and postpartum care after delivery, in addition to cesarean reduction. We were also recognized for the Quest for Zero initiatives to eliminate preventable errors. And the hospital is one of the first hospitals to implement, in the Bay Area, to implement Eat, Sleep, Consult program. And this is to support babies born to mothers with substance abuse issues. Next slide. The previous report noted diabetes hospitalization rate and youth obesity was alarmingly high in Union City and Newark. During focus group interviews, community members mentioned healthcare providers did not give culturally specific recommendations. And to address this, we had tailored our Diabetes Matters program to provide health information targeting specific populations. We also led 2 annual diabetes alert screening events to raise awareness of the seriousness of diabetes and prevention information. And the hospital also participated in 19 health fairs. Next slide. To address unintentional injury, Washington Hospital Sports Medicine acquired iSync, a cognitive assessment tool to test for concussion at high school sporting events. Our athletic trainers hosted first aid stations during 10 Special Olympic tournaments. And to address violence, the hospital continued partnering with local drug rehab center to facilitate our tattoo removal program to help young adults make positive changes in their lives by removing symbols of their negative past. And we have an established relationship with Safe Alternatives to Violent Environment, which provides support services and education against domestic violence in our community. And the hospital is one of 3 hospitals who partner with Alameda County's sexual assault response team. And this includes nurse practitioners, sexual assault advocates, and police officers to assist survivors. Next slide. And that was to highlight a few key initiatives we accomplished from the previous report. A comprehensive report is available in our current report. Now let's jump into the 2019-2020 Community Health Needs Assessment. Next slide. First, let's review the makeup of our community. Washington Hospital's primary service area includes Fremont, Newark, Union City, unincorporated Sunol, and the hospital's primary service area also includes a small portion of South Hayward. The estimate of the population in our district is 365,000. Next slide. The next couple of slides shows the age breakdown for Newark, Fremont, Newark, and Union City. In Fremont, the population is slightly population is also stable. In regards to race and ethnicity, Fremont and Union City have a large Asian population, and Union City also has a sizable Latinx population, as does Newark. And the Black population is significantly smaller, with less than 5% in each of the cities. Next slide. Now I will begin diving into the top health needs, and they are behavioral health, housing and homelessness, healthy eating, active living, healthcare access and delivery, social determinants of health, diabetes, heart disease, hypertension and stroke, and respiratory health. Next slide. Behavioral health, including mental health and substance use, is a high priority in the community. The ED visit rate for severe mental illness is higher in Newark, Union City, and unincorporated Sunol than the Alameda County rate. Please note, yellow cells represent data that is worse than the county by 5% or more. Regarding substance use, ED visits was highest in Newark, yet lower than the county benchmark. Next slide.
Lucy, I think we're unsynced with the slides here. Could you go forward, Shri? One more. One more. There we are. Thank you.
Okay. Behavioral health. The most common types of self-inflicted injury are related to poisoning, cutting, in addition to suicide attempts. The self-inflicted injury ED visit rate for those under the age of 2018 was highest in Fremont and highest in Newark for adults. All cities below the county, and all cities were below the county benchmark. The self-inflicted hospitalization rate is slightly higher in Newark than the county rate. Although suicide rates in all cities were lower than the county, the suicide rate in Fremont was highest since 2012, and there's an upward trend in Newark. Next slide. Housing and homelessness ranked as a high community priority. Participants strongly linked housing with behavioral health, stating that the stress of keeping a roof over their heads has a negative impact on their families. The Area Deprivation Index, ADI, is used to measure the lack of basic necessities. And the ADI has been linked to poor health outcomes such as 30-day rehospitalization rates, cancer incidence, cardiovascular disease, and mortality from all causes. The ADI chart on this slide highlights that crowded homes, rent, and monthly home costs are higher in our district than the county. And the number of residents living in overcrowded homes has increased since 2011, and nearly half of the residents in Newark and Union City spend 30% or more of their income on rent. Next slide. Following a countywide trend, the number of people experiencing homelessness in Fremont, Newark, and Union City has greatly increased in 2019 from 2017, and the number of unsheltered individuals nearly doubled. And Fremont is ranked the third highest in the county with the number of homeless people. People who are experiencing homelessness are at a greater risk of preventable illness, require longer hospital stays, and face a greater risk of premature death. Next slide. Healthy eating, active living was found to be a health need. Parents interviewed shared their concern having difficulty encouraging their children to adopt healthy habits. We learned through the statistics, aerobic capacity and body composition has been getting worse among our youth in our district. Youth in Union City fare significantly worse in meeting the aerobic capacity standards than their peers in the county. And based on measures of body composition, youth in Newark and Union City are more likely to be at the high risk than their peers in the county. Next slide. Access to healthcare is important to everyone's quality of life. This includes insurance coverage, adequate numbers of primary care, and specialty care providers. Delivery of care includes quality, timeliness, and cultural competence. Population with health insurance improved in Fremont, Newark, and Union City. However, community members shared that they cannot afford out-of-pocket costs, particularly due to high deductibles. And they also expressed concern that there's a lack of specialists, particularly in geriatric care and behavioral health specialists. And language may be a barrier to access to healthcare. And statistics here reveal that close between 1 to 5 people speak limited English across our district. Next slide. Economic insecurity was also ranked as a high priority in our community. Children in poverty and unincorporated SNOL is much higher than the county. However, it should be noted that data in small communities and random variation, the data or percentage may be substantially different from year to year. And the data here shows that fewer adults in Newark and Union City have a bachelor's degree or higher than the county. However, according to a public health expert interviewed, residents with college degrees may be vulnerable to poverty, and during interviews, participants emphasized that local jobs do not pay workers enough to afford the high cost of living. Next slide. Diabetes, heart disease, and stroke are among the leading causes of death nationwide. The rates of ED visits and hospitalizations for diabetes are higher in Newark and Union City than the county rate. Heart disease hospitalizations are higher in unincorporated SNOL and Union City than the county. Unincorporated SNOL also has a higher rate of ED visits for heart disease when compared to the county's rate. Next slide. Congestive heart failure hospitalization rate is lower than the county rate. And heart disease mortality rate in Fremont has improved, as did the county rate. However, Union City is significantly higher than the county and the poorest since 2011. Next slide. Mortality rates for ischemic heart disease, also referred as coronary heart disease, in Newark and Union City are higher than the county and poorest in Union City since 2013. acute myocardial infarction mortality rate in Union City is significantly higher in the county and worse since 2011. Next slide. Hypertension is also an issue as evidence of the rate of hospitalizations in unincorporated SNO and by the rate of ED visits in Union City. I also included in the slide trend data of Washington Hospital ED visits for hypertension. And here you can see that there is a significant upward trend from fiscal year 18 to fiscal year 20 in all three cities, Fremont, Newark, and Union City. It is also worth noting that the hypertension mortality rate in Newark is much higher than Fremont, Union City, and the county. Next slide. The rates of ED visits and hospitalizations for stroke are higher in Newark and Union City than the county rate. It also should be noted that healthcare providers are seeing an increase in dual diagnosed with stroke and diabetes. And stroke mortality rate has decreased in all cities in addition to the county. Next slide. Data shows that the rates of COPD-related emergency department visits and asthma hospitalizations in Newark and Union City are significantly worse than the county rate. Although we do not have trend data, previous reports have similar results. Next slide. Although cancer was not identified as a health need in the 2019-2020 Community Health Needs Assessment, it still remains a community concern. Community health concern. Despite this slide, this slide depicts a decline of various cancers in the Greater Bay Area, including Alameda County, from 2007 through 2016. And however, during the same period, annual incident rates increased for the three cancers, malignant melanoma, thyroid cancer, and uterine cancer. Next slide. Regional statistics also show that over the past decade, annual mortality rates declined for most cancer. The only mortality rate with a significant increase was uterine cancer. Next slide. Although there was a decline in cancer incidence and mortality, cancer is still the second leading cause of death in the United States after heart disease. And as a result, we are committed to address this health concern. Our cancer care program offers a full array of treatment options for patients who have received a cancer diagnosis. Next slide. And to wrap up our presentation on the findings of the 2019 Community Health Needs Assessment, we have aggregated the disease incident data for the major three cities in our district. For each of the 25 diseases noted in the assessment, this chart shows the prevalence of the condition in the city and in comparison to Alameda County rate average. Bars pointing to the right show diseases that with a greater prevalence than the county. So for example, in Union City, the ischemic heart disease mortality is at the top of this chart with 145.7% of the county average. This chart highlights that the population of Union City has a disproportionately high incidence of cardiac-related conditions, ED visits for COPD, diabetes, and hypertension, just to name a few. On the other hand, Union City is doing much better than the county as a whole with mental health-related conditions such as suicide and self-inflicted injuries. Next slide. The chart for Newark reveals a similar story. The residents of Newark have a disproportionately high levels of ED visits for COPD and stroke, and asthma is also a major concern with hospitalization rate of 36.9% higher than the county. There also appears to be a significant incidence of mental health conditions requiring ED visits. Next slide. Finally, in Fremont, the incidence of all 25 disease measured is below than the county average. And that being said, the incidence of cardiac-related conditions is still near the county average, along with asthma and diabetes. Next slide. I would be remiss if I did not discuss the current health crisis, and that is COVID-19, also known as coronavirus. This global pandemic has launched many new challenges nationally and locally. In response to the pandemic, the hospital initiated and increased several infection prevention control measures. We implemented the rapid screening and treatment unit and began offering mobile COVID testing at skilled nursing facilities, long-term care facilities, and other businesses. We also began hosting coping presentations related to COVID pandemic on Facebook Live. And the hospital is committed to ensure the safety of our patients and staff while continuing to monitor the measures as the pandemic evolves. Next slide. So that concludes the findings we learned, and now the last set of slides, I will share how we plan to address them. We will develop a multi-year, multidisciplinary community health plan, improvement plan for our board of directors to review on October 28th, at the October 28th meeting. For behavioral health, we will explore various collaborations, including UCSF Adolescent Behavioral Health Services and the Medical Explorers Post 539 to focus on mental health issues with our youth in our community, in addition to community education. In response to housing and homelessness, we will strengthen our partnership with city programs such as Fremont's Mobile Evaluation Team and the Homeless Task Force to help identify homeless services and resources available through our district. In response to healthy eating, active living, we will explore a collaboration with our East Bay Regional Parks District to participate in existing programs to promote health benefits of physical activity. Next slide. To address healthcare access and delivery, we will explore plan options with various insurance companies such as Canopy Health and United Health to broaden our access. In regards to social determinants of health, we will continue partnering with local chambers of commerce and other business-focused organizations to promote and foster business growth for potential employment opportunities and participate in college and high school career exploration programs. To address diabetes, heart disease, hypertension, and stroke, we have many clinical offerings to enhance the support of our community, and we will add additional focus in the prevention and treatment of ischemic heart disease given its high prevalence. In addition, we will explore achieving the Joint Commission thrombectomy capable stroke center certification, establish a transcatheter aortic valve replacement program, and participate in a county-led stroke study with doctors Jeffrey Thomas and Jack Rose. Next slide. In regards to respiratory health, we will explore partnering with Alameda County Public Health Department's Asthma Start program to work with families with children with asthma and increase community awareness of the benefits of respiratory testing and pulmonary rehab through our health and wellness program. And to address cancer, we will implement the state-of-the-art linear accelerator, improve community awareness of our low-dose lung cancer screening program, and implement a cancer survivorship program, and continue community education. We will continue to build on the plan with additional initiatives as they are identified. Next slide. We will share our findings of the 2019-2020 Community Health Needs Assessment and Implementation Plan when approved with our community stakeholders. And the full report will be available for our community members on our website. And thank you for your time. Any questions?
Wow, that was a really great and thorough report. I mean, that was really well done. Any questions from any of the board members? You know, you keep hearing about what the long-term effects of COVID will be on people who have got it. I think we'll have to be alert to see what the developments are in that area as we go through this pandemic. Okay, well, Angus, you look like you were going to say something. I don't know.
I was actually, and all I was going to say was we're going to bring the health improvement plan to the board at the end of the month for your review and bring it to the board meeting next month as an action item as well. But thank you it's a lot of material in a short period of time, so thank you for speaking to that.
Yeah, they'll be later on this month, not next month, right?
This month, that's right.
That's right. Okay, well, thank you very much,
Thank you.
Angus and Lucy. Thank you very much.
Thank you.
Thank you.
All right, we're going to now move to the medical staff report for Dr. Killaroo.
Thank you. So we currently have 584 members on the medical staff, out of which 349 are active. We have 1 administrative member and 98 ambulatory members.
Okay.
That is it.
All right. Well, thank you. Um, Okay, Kimberly, we're going to take on the quality report.
Yes, this evening we have Dr. James McGuire, who is the medical director of the special care nursery, and he's also where he practices neonatology, and he is going to be giving the annual report for the special care nursery. But I'm just going to introduce him briefly to everyone, though I know he has presented to the board in the past. Dr. McGuire is a professor of pediatrics at the University of California, San Francisco, and he practices and teaches not only at Washington, but at the UCSF Medical Center at Mission Bay. Dr. McGuire received his undergraduate degree from Harvard, his medical degree from the University of California, San Diego, and a master in public health degree from UCLA, where he also completed a residency in pediatrics and a fellowship in neonatology. His work interests include team harmony and collaboration. Dr. McGuire is fond of the Bay Area, having grown up here, and currently lives in Fremont with his wife and 2 children. All right, thank you for joining us this evening, Dr. McGuire.
Well, thank you for having me, Kimberly Hart. Thanks for the kind introduction. It's a pleasure to be here to the board members, the members, and the folks in the boardroom, and the rest of the community that's listening in. Yeah, so this is our annual board report. And so I didn't put this report alone together. I put it together with many others, and I just want to say it was a team effort, and I really appreciate everybody's help. Next. So the background is that the Washington Hospital Special Care Nursery was established in a partnership with UCSF in March 2014. This affiliation shows that the physicians are collaborating and working alongside the Washington Hospital nursing and ancillary staff. And our goal is to have comprehensive and integrated care for the community, meaning not just from at birth, but actually even before birth. And now we have our perinatologists who's very involved from UCSF in terms of our more complicated patients. And then we try to aim for a seamless transition for infants requiring a higher level of care. And so we are in close contact with our colleagues from UCSF if we have to transfer baby. I also want to speak to our new leadership on the second floor, and particularly Kelly Franklin, who's the Director of Maternal Child Health Services, and Michelle Dishman, who's the SCN Manager. The Special Care Nursery, just to give you a sense of what it is, so it's a level 2 neonatal intensive care unit. That means that we don't take babies down to all gestational age. We usually aim to stop at about 32 weeks or about 2 months before the due date. And in 2019, we had 1,540 deliveries, as you can see, births, and about 10% were admitted to the Special Care Nursery. Our average daily census was around 4, and you can see our patient days and average length of stays followed. I want to step back for a second and talk about the COVID-19, of course, because that's been a huge issue, huge focus for not just the hospital, but for the SCN this year. And so for speaking to the hospital part first, just in brief, is that, of course, for all patients now who have symptoms of COVID-19 prior to and upon arrival, they get screened. There's immediate isolation of symptomatic and high-risk patients, universal masking. As you can tell by everybody in the room, our safe restricted visitor policy, and then elective surgery, there has to be mandatory COVID testing and so forth, and we work with the public health and local health care facilities. Regarding the Special Care Nursery in the second floor, where there's the birthing center, we've had we put a lot of effort into coming up with standard work and training for COVID. That was a huge challenge, as it was for the whole hospital, because of course all this was new. But in any case, we've worked on patient and healthcare worker safety, donning on and off personal protective equipment, testing, patient education. And we had multiple remote meetings to discuss and continue to discuss what we should do for our COVID response on the second floor for both the Special Care Nursery, the moms, the babies, and so forth. I want to move on to our quality and strategic initiatives. So these are initiatives that are sponsored and supported by the Special Care Nursery Clinical Operations Committee, which meets monthly. This committee is multidisciplinary, and we have nurses, doctors, respiratory care practitioners, occupational therapists, and others. At this meeting, we've looked at virtual rounding, donor breast milk, and an eat, sleep, console approach to at how to best take care of babies who are withdrawing from narcotics, and I'll talk about each one of those. And we also addressed simulation training to enhance our patient safety outcomes. So the first was our virtual rounding. That's the associate medical director, my colleague, Dr. Nahid Rustami, and she came up with this idea. It wasn't that we actually started this in light of the COVID. Actually, we put a lot of planning into this in 2019 and basically had everything ready just around the time that COVID became a reality in the United States. So the virtual rounding is that enables us to round without the parents being there. We feel that family-centered care is really the best way to go in terms of best outcomes for babies, for moms, dads, so forth. And so we have 2 iPads that we use to reach out to families who are unable to be at our daily family-centered rounds. And then that keeps the family involved in their baby's care and decision-making. And the surveys of the families have been positive. We have a nurse champion who's helped and tracked the challenges that we face, because there are always challenges. I think sometimes we've had a case or two where a family member has with essentially FaceTime when they were not in the perfect situation to do FaceTime. Let's put it that way. So we've had to realize that we want to use it, but there's a balance, and so but it's really worked well in terms of communicating, and in terms of the pandemic, it's really been fantastic to communicate with families. In terms of donor breast milk, we rolled that out in late 2019, so we haven't even been doing that a year. And so we had to meet licensing regulation requirements. There's this tissue license requirement that we went through a process to obtain, and we obtained that. In the first quarter of 2020, about 59% of our patients received donor breast milk, and we feel that that's a really good thing, as opposed to formula. Formula is still an option, but if there's not enough of maternal breast milk, then we have given this as an option, and we feel that that has improved the care and actually satisfaction of the families. Eat, Sleep, Console. So the Eat, Sleep, Console approach is an approach that has been becoming the norm across the United States in the last 5 to 10 years or so. This came out of Yale New Haven, and it's an approach of where moms are typically on narcotics during the pregnancy, and then the babies are withdrawing after the birth because they're no longer receiving the narcotics that they were receiving while they were inside the mother. And so we looked at a newer, better approach that enables the babies to stay with the mothers more. And so that has been seen as a better for bonding, better for long-term care, and it can be done safely. We put a lot of effort into it. Many members of our team were involved in an approach, both not just in the special care nursery, but also in the birthing center. And so because of that, fewer of these babies, half of those babies, 3 of those babies would have probably come to the special care nursery, because anytime we used medication in the past, we would have brought the babies to the special care nursery. We were able to use our pediatric bed spaces area to keep the babies with the mom on some cases, and that avoided the babies going to the special care nursery and improved bonding and outcomes. So we're very happy with that. Our antibiotic use. So we submit, let me just explain, the California Perinatal Quality Care Collaborative. So that's a database organization, and also puts out quality improvement suggestions for California. And so the California Perinatal Quality Care Collaborative gets information from us that we submit, and then we can compare it with other units, neonatal intensive care units in California. And Washington Hospital has a lower antibiotic usage than the California average. And even if we parse that out into the level 2, which is the intermediate level 2 units, we are still lower than the average. And we're trying to think of this as our antibiotic stewardship, and which is good for our babies. The other quality data that we follow is a metric on central line associated bloodstream infections. This is done in all intensive care units. We use central lines. We don't use them a lot, and so we don't have a lot of days. In 2019, for the first half of 2020, we've had no central line associated bloodstream infections, which we're very happy about and put a lot of effort into that. Another quality initiative has been focusing on communication. So it's a real challenge because we have multiple providers in our taking care of the mother, sometimes taking care of the mother before she delivers, like our perinatologist, and then the mother in the hospital, and then on the baby after birth, and then we have the nurses and all that. So we have huddles. These like a high-risk huddle. If we think a premature baby is going to deliver, we try to get all the members of the team together to discuss any issues that we need to all be aware of, and then also plan out that resuscitation, since we don't resuscitate a lot of extremely premature babies. The second thing is our clinical care conference patient care plan, which is essentially what we've been using with these more complicated patients that now Dr. Jackie Chu has been taking care of, and that have issues that then can be a little more challenging to make sure we're providing the best care. And so we now have a way of entering that into the mother's chart, and if the baby, for example, has a heart concern, then when the mother comes in, we will look at the mother's chart. Everybody will get together, nurses, doctors, OBs, anesthesiologists, and whatnot, and say, oh, okay, so this is the situation, this is the plan that we put together, and then we're ready to go. And we continue to look at other ways of improving communication. More recently, we've been doing a safety huddle daily, which has been improving the communication in terms of the deliveries for that day, in terms of who's in labor and delivery. Education and professional development. This is ongoing. We have case studies with nurses, pediatric hospitals, and neonatologists from Washington Hospital. We did that just last week. And then we also have UCSF outreach courses for the nursing staff on neonatal nursing care, and our nursing leadership coordinate with UCSF nursing outreach for that, and they do labs and critical ill transport issues. And then we have a quarterly UCSF perinatal outreach program, which has faculty from UCSF who are involved in cases or topics that we feel is relevant for the hospital and for even the outpatient community. Patient experience. We have a lot of positive comments from families, and the quotes, so to say it, I felt completely safe leaving my newborn in their care. They are the best. And the nurses in this SCN, which I would state also are very nice and professional, very patient. So we're very excited about these comments. In terms of the actual metrics, the data, these are, the SCN is actually mixed in with all the data on the second floor, so we think that this is relevant, but we're also looking at ways of trying to get special care nursery specific information, and so that's something that we're aiming for in the coming years. But the bottom line is that our metrics on that have been fairly positive. We would obviously like to be higher, and we continue to endeavor ways of trying to get higher satisfaction. Our annual SCN reunion was last in 2019. I think it was in September, and so we were planning on having one this summer. Because of the pandemic, we had to cancel it. As you can see, this was a Western theme. That's myself with the black cowboy hat and the twins. We have a lot of twins because a lot of twins end up being born premature, and then we have them for the last, from various ages. And then I also want to put a shout out to our volunteers who also make this reunion what it is and make our unit what it is. That's, for example, is Jill, who is one of our cuddlers, and Jeannie Yee, who's one of the board members, and many others have been just fantastic in terms of helping with the cuddling of the babies and then providing blankets and names for the babies. We've had personalized names for the babies for 6 years, and then that's been more of a challenge with the pandemic. We're really looking forward to our volunteer cuddlers coming back when that is appropriate. but we're obviously happy that they're safe right now. Our next steps, I mentioned that California Perinatal Quality Care Collaborative, and so that looks at, as I mentioned, strategies for improvement initiatives, and we continue to work with them to see if there's anything that we can glean from them. And they have even a new work group which we're looking into that can address the challenges of small NICUs. What we actually get the most information from is this UCSF Northern California Neonatal Consortium, and the neonatologists, the nursing leadership, participate in these, and we provide clinical guidelines used by multiple hospitals in the sort of UCSF Northern California family. And so we continue to participate and create those guidelines and have had influence on those guidelines. We're also looking into trying to get more transfers to Washington Hospital as appropriate. It's the families that transfer their babies back here are always thrilled to be back here to avoid the drives across the bay or far away, and with the traffic, it's just always a challenge, and it's easier to work on breastfeeding, and we feel it's better for the families, and we're always looking at options for that. We're looking into the level 3 designation down the road. We're also working on more simulation with high-fidelity mannequins that was sort of been put on hold with the pandemic in particular recently. So we're getting that going. And then infant-driven feeding, which is more of it's a national approach that's become the norm to have the babies sort of direct the feeding, and that we feel has better outcomes long term. We're continuing to look at lean and Kaizen activities in the special care nursery so that we can have standardization and have people have their expectations, we have clear expectations and know what to do. And as I said, we're looking forward to welcoming back our volunteers. That concludes my presentation. Were there any questions?
No. Great program. Thank you, Dr. McGuire.
Oh, thank you. Glad to be here.
Thank you. All right, then we're going to move on to Chris Henry and the finance report.
Thank you, Dr. McGuire. Moving seats around. Thank you.
Okay, so tonight we'll be looking at the operating and financial results for Washington Hospital for August 2020. Average daily census for the month. As we've seen the last several months, the census statistics point towards longer lengths of stay. Our admissions are down 44 in the month, but our average daily census up 23.9, and our patient days above budget by 741 at 5,020. Outpatient observation days for the month came in 11 above budget at 173. And as I mentioned, our average length of stay ended up at 5.75 for the month. We expected 4.94 in the budget. Case mix index continued to be high in August at 1.648. We had 122 deliveries in August. That's 29 below the budget. Surgical cases were 41 below the budget at 348. That was largely driven by joint replacement cases that were 39 below budget at 128. And one of our orthopedic surgeons ended up being out unexpectedly during August. Neurosurgical cases, however, were above budget by 6 at 24. Our cardiac surgeries for August were 8 below budget at 5, although we did see some improvement in that in September. Cath lab procedures were 52 below budget at 306. And our outpatient visits were 459 below budget at 6,773. That was largely driven in the areas of X-ray and cardiac rehabilitation. Emergency room visits, including RSTUs, overall 348 below budget at 5,646. Of those 5,646, 1,951 were RSTU visits. That was 171 lower than budget. We're starting to see those visits in RSTU come down. As you recall, we've been seeing those numbers up around 2,500 earlier in the year. So those are starting to come down. Regular ED visits for the month were 3,695. That was off of budget by 177. Here's a look at our cath lab activity pie chart. Cardiac visits for the month made up 44% of the visits. And cardiac activity in the cath lab has been increasing. It was above budget. We had 134 procedures. Those were 15 above budget. Peripheral vascular procedures came in at 30%. We are short in August a physician, but we've had a new one start just in the last couple of weeks. So hopefully we'll see those peripheral vascular procedures starting to come back up. Non-vascular interventional radiology for the month came in at 24% of the activity. Those procedures ended up at 73. That was 9 below budget. And our neurointerventional radiology procedures were 2% of the activity. Those were up 6 from budget at 7, so that's good for the cath lab. Looking at our productivity, productive FTEs continue to be high at 152.2 above budget at 1,387.6, had 159.3 non-productive FTEs in the month, giving us total FTEs that were 138 above budget at 1,546.9, but our full-time equivalents per adjusted occupied bed, that's our productivity standard, pretty close to budget at 6.39. So the higher census really driving a lot more FTEs. Moving into the financials, and as always, we'll look at our Governmental Accounting Standards Board presentation. This is, for the people of the public, this is the presentation we use for our audited financials. Total patient revenue for the month came in $5 million above the budget at $172,131,000. Our contractuals for the month came in at 77.62, a bit higher than what we had expected at 77.2%. And that was made up of our contractual allowances, which include the write-offs that we are contracted to write off to private insurance companies and, of course, government payers, really came in higher than we expected. Government payers made up 71.5% of the activity in that bucket. We end up writing off more for the government payers, and our PPO for the month came in at 22.9% of gross revenue. We'd expected 24.4%. So that shift really drove higher contractuals for the month. Likewise, we had provisions for bad debt and charity that were $636,000 above the budget at a little over $4 million. So we, again, ended up with total contractuals and write-offs a bit higher than budget. So that resulted in net revenue landing about $350,000 above budget at $38,739,000 for the month. Operating expenses for the month came in almost $2.9 million above the budget at $41,936,000. And that variance almost entirely driven by our higher salaries and benefits that were driven by our higher FTEs in the month. So we ended up August with operating bottom line actually showing a loss of $3.143 million for August. Non-operating income came in $914,000 above the budget at $960,000. We did receive another almost $1.1 million in HHS subsidy money in the month. And we had a small unrealized loss on our investments of $150,000. Do want to point out that rental income is down about $106,000 at $145,000. that largely being driven by the Peterson Dean bankruptcy issue. That made up $84,000 of that variance. Also, with COVID, a number of our tenants are struggling to make rent. So we're trying to work with them as best we can to keep them in the building long term and help them through this crisis. So we ended up the month with a total loss of $2,183,000 from a GASB perspective. Moving into our FASB presentation, and this includes some adjustments that might be made when Wall Street looks at our financials. First one they make is to move about $716,000 of revenue bond interest expense out of non-operating income and back up into operating expenses, which changes our operating loss from a FASB perspective to $3,859,000. We then adjust out the interest expense related to the debt service on our general obligation bonds, and we end up, also we take out that $150,000 unrealized loss on our investments to end up with non-operating income from a FASB perspective of a little over $1.5 million and a total bottom line of showing a loss of $2.3 million. Now we'll look at our earnings before interest, taxes, depreciation, and amortization, and we make some adjustments here to try to estimate how much cash our operating and non-operating activities are generating. So we adjust depreciation out of our operating expenses because that depreciation is a representation of cash flow that's actually happened in the past. And so we adjust out that depreciation of about $4 million, and we end up with EBITDA at about $859,000 for the month. Likewise, in non-operating income, we adjust out our interest expense. And if you look at our other non-operating income and expense line, our non-operating activities generated about $2.8 million in the month. So in total, our operating and non-operating activities generated about $3.7 million, which will be used for the debt service on our bonds and other capital and programmatic needs. So are there any questions on August's results? Okay.
All right,
Okay,
I will,
go ahead.
sorry, go ahead.
No, go ahead, please.
All right, then I will present the September preliminary operations report. So to begin with, looking at the gross revenue of $172 million for September was above budget by $5.9 million and above September of 2019 by $12.5 million or 7.8%. Specifically, inpatient gross revenue of $110 million was above budget by $4.4 million and $6.4 million above September of 2019. And outpatient gross revenue of $62 million was above budget by $1.6 million and $6.1 million above September of 2019. Looking at our key census, average length of stay of 5.90 was above the budget of 4.93 by 0.97 or 19.7%, resulting from the significantly higher, there were really two things, the higher acuity of the admitted patients. And if you look at the average length of stay was also longer than the September 2019 average length of stay of 4.46 by 1.44. So, the longer length of stay especially when compared to the prior year, is a couple of things. As I said, I think we're seeing higher acuity patients, so that's one piece of it. The second, and I'm going to talk a little bit more about this, is the shift in joints from inpatient to outpatient. And that's also driving up our length of stay. So I'll have a graph that I'd like to show you coming up, and that will explain it a little bit more. Looking at outpatient observation days, were 55 or 34.6% above the budget at 214 days. and our average daily census of 143 was above the budget of 139 by 4 or 2.8%. Again, in terms of admissions, they were below budget by 48 or 5.7%. Admissions for the month were 121 below the September 2019. Again, due in part to the shift in joint surgeries from inpatient to outpatient. And again, we had longer length of stay, but less admissions. So the patient days, our patient days of 4,279 were above budget by 116 or 2.8%, and patient days for the month were 144 above September of 2019. This is aligned with our length of stay. So looking at our surgical trend, our total surgical cases in September of 367 were below budget by 11 or 2.9%, but the surgical cases were 28 or above September of 2019. Inpatient surgeries were 27 or 13.9% below budget at 167 and 32 or 16.1% below the September 2019 volume. Our outpatient surgeries were 16 above budget at 200 and 60 above September 2019. So breaking down our surgical activity, our general surgical procedures were below budget by 20 or 10.5%. Our joint replacement surgeries were below budget by 1, so pretty much right on. Our neurosurgical procedures were above budget by 5 or 22.7, and our cardiac surgical procedures were above budget by 5 or 71.4%. So we had some strong numbers in neurosurgery and cardiac surgery especially. Okay, so now I want to talk a little bit about our joint replacement surgery trends. So if you look, our inpatient joint replacements are characterized by the blue line, and our outpatient volume is the red line. And so this is really showing the impact that we have been seeing. So prior to fiscal year 2019, you can see that the majority of our joint replacement cases were done as inpatient cases. And then, as we've talked about here in the past, CMS removed the total knee replacements from the inpatient-only list in 2018. And that relationship changed to roughly, as you can see, the inpatient to outpatient relationship changed to about 50% inpatient to 50% outpatient procedures. So that continued for a number of months. And now, as we've talked about recently, the CMS has removed total hip replacements from the inpatient-only list. And so the majority of our total joint replacements are now being performed as outpatient cases. So if you look at now, July, August, and September, when now both the knees and the hips are not on the inpatient-only list, you can see now it is, in September, approximately 72% of all joint replacements were performed as outpatient cases versus the inpatient cases. So that's really seeing the trend. And then as we've talked about further trends, there is the discussion about moving joints even to the ambulatory surgery center side of things too. That this has been impacting our trends in terms of volumes in inpatient and outpatient. So hopefully that was able to show that better. All right. Moving on to cath lab trends. Cath lab procedures for September of 380 were 28 or 8% above budget, but 8 or 2.1% below September of 2019. Our inpatient cath lab procedures were above budget by 26 or 12.4% at 236, and our outpatient cath lab procedures were above budget by 2 or 1.4% at 144. So then breaking down our cath lab activity, our peripheral vascular procedures were below budget by 16 or 10% and 30 or 17.2% below the same period of last year. Our neurointerventional radiology procedures were above budget by 1, pretty much right on, and 3 above September of 2019 volume. Our cardiac procedures were above budget by 15 or 12.1%, but 6 or 4.1% below the September 2019 volume. And then our non-vascular interventional radiology procedures were above budget by 28 or 43.8%, and 25 or 37.3% above the September 2019 volume. Our deliveries continue to, we've been struggling with a lower volume in deliveries, and so for September we're at 113, which is below budget by 19 or 14.4%. Looking at our non-ER outpatient trend, our non-emergency outpatient visits of 7,092 were above budget by 15. These visits were below September of 2019 by 934 or 11.6%. Looking at the breakdown, our EKG visits were above budget by 117 and 109 above the prior year. Our lab visits were above budget by 181, but 160 below the prior year. Our cardiac rehab visits were below budget by 237 and below the prior year by 355. And our x-ray visits were below budget by 100 and 415 below the prior year. So we're still seeing some challenges in terms of some of the non-emergency outpatient visits. Also with our emergency room visits, there were 3,482, which were below budget by 442 or 11.3%, and below the same period last year by 820 or 19.1% of visits. So again, continue to see some challenges in really our emergency room visits coming back. Also, the RSTU, the Rapid Screening and Treatment Unit, you can see there were 1,260 visits, which were below budget by 794, which represents a decline of 54% since the peak of 2,762 in July. And I think really the overall reduction that we're seeing in Alameda County of the number of positive cases, we're just, as you know, the RSTU is focused on either symptomatic patients or exposures. And we've really seen those numbers overall in Alameda County and Southern Alameda County drop off, which is, I think, also impacting our RSTU, which in a sense is good in terms of not seeing as many symptomatic patients for COVID. All right, moving on to the gross revenue. Emergency room visits were below budget by 442, driving emergency revenue down by $1.4 million or 12.9%. Our surgical cases were below budget by 11 or 2.9%. However, surgical services revenue was up by $1.6 million or 4.7% due to the mix of procedures. Our inpatient days were above budget by 116 or 2.8%. Driving room and board revenue up by $2.2 million or 6.9%. The higher level of inpatient activity also drove ancillary revenue above budget by $4 million or 5.4%. Looking at our payer mix, we still have challenges on our payer mix side. Our government-sponsored patient revenue made up 72% of gross revenue, which is higher than the budget and the prior year. It's not as high as what we saw in August, but it is still above the budget of 71.2%. HMO was 3.1% of gross revenue, which is above budget by 2.6% and higher than the prior year at 2.7%. Our PPO was 23.2% of gross revenue, which is below budget of 24.2% and lower than the prior year of 26.6%. And a good thing, our private pay was 1.7% of gross revenue, which is below the budget of 2% and lower than prior year of 2.6%. Our preliminary, preliminary productivity indicators. Our productive FTEs were above budget by 141 at 1,366.5. Our non-productive FTEs were above budget by 3.5 at 181.1. So So overall, our total FTEs were above budget by 137.5 or 9.8%. Some of this is definitely driven by our volume, but it's also driven by some of our COVID FTEs that we still have retained in terms of trying to assist with our COVID patients. Our productive FTEs per adjusted occupied bed of 6.13 were higher than the budget of 5.62 at 9.1%. And our total FTEs per adjusted occupied bed of 6.94 were higher than the budget of 6.46 at 7.4%. So we do have work to do in terms of working to reduce our FTEs in line with the budget numbers. So that is something that we are going to be focusing on. Moving on to other operational statistics, our Washington Outpatient Surgery Center cases were above budget in September by 6 or 1.5% at 417, but this was 91 below the September 2019 volume. Our clinic visits of 2,966 were above budget by 387 or 15% for the month of September, but were below by 362 the September 2019 volume. So we have seen Washington Urgent Care increase in visits there. Also with our Danielson Clinic and our Nakamura Clinic, we've seen some additional growth there in terms of visits. We did have one of our other doctors, Dr. Singh, move from the Warm Springs Clinic to a new State Street location, and we have a new physician that's actually going to be joining the Warm Springs Clinic, or I should say has joined just recently that clinic. So we will continue to see some growth there. Moving on to key financial statistics and charity, our days cash on hand for September ended at 176 days. It is a decrease of 9 days from last month, but this is due to funding of the pension that we knew that we needed to do at around $9.9 million. We do have one more funding of the pension that we have to do before the end of the year, and that's going to be another approximately $10 million to fund. So our days of gross revenue and accounts receivable were 61. Higher volume of higher dollar and higher acuity patients compared to last year, as you can see, was at 53. There were 585,212 in charity care applications pending or approved in September, which is below both the prior month and the prior year. All right, moving lastly on to the homeless patient activity. There were 208 homeless patient encounters in September 2020. Estimated incremental cost of Senate Bill 1152 for the month of September is $100,000. And our estimated total unreimbursed cost of homeless care for the month of September is $409,000. And estimated total unreimbursed cost for the homeless care for fiscal year to date is approximately $1.1 million. And then the next slide, as you know, just breaks it down. You can see the red portion of the bar graph represents the estimated incremental cost, and the yellow portion of the bar represents the total monthly estimated unreimbursed cost, but excluding the incremental cost. So you can see sort of our trends that way. All right, that is the September operations report.
Well, thank you, Kimberly. Are there any questions from the board members? Okay, well, got a lot of hard work to do. It's a tough world we live in today, that's for sure. And I know you're just doing the best you can be doing under the circumstances, Kimberly and team. So, any announcements, Kimberly, that you'd like to make?
Yeah, I do have a couple of announcements. I do want to just, let the community know that we continue to do our health promotions and outreach activities, and we've been having some really good community support of these. We had Dr. Prasad Kilaru on September 17th. He did a seminar on our Washington Center for Wound Healing and Hyperbaric Medicine. And he presented on the latest treatment options, and we had 72 members participated in the live event, and then 280 have accessed the presentation since that time. We've also had Dr. Victoria Leapart. She spoke on strengthening your immunity on Zoom, and we had 35 members attend that seminar virtually. We also have been busy with flu shots. I think you know the importance this year of getting flu shots. Since September 19th through October 10th, we've had a couple of different flu vaccination drive-through clinics through Washington Urgent Care and Washington Township Medical Foundation. And we have given 1,050 community members flu vaccines. So we've been really focusing on that. We have one more drive-through clinic that will be held on Saturday, October 24th from 9 to noon. I will say, and it's important that people get there early because we tend to run out of vaccines. So that is something that's been very well received from our community. We also had Christy Caracappa in October 6th and 7th present information on Medicare open enrollment. What you need to know, we had 112 community members participated in the live event, and also 266 people accessed the presentation. So that's an important topic for our community. We had Dr. Nord that talked about ortho overuse injuries, prevention and treatment. We had 79 members of the community participated in the live event, and 88 people accessed it after the presentation on one of the social media channels. And we also had Dr. John Pastoris. He is a specialist in orthopedic surgeon in shoulders, and he presented on shoulder pain causes and treatment options, and we had 72 people access this live event. And so our community can access it at any time, any of these types of lectures on the InHealth YouTube channel and or through Facebook too. I also do want to say that we had a very successful Top Hat Gala on Saturday, October 10th. It was our first ever event that we hosted virtually, or our annual event that, as we know, is usually in person. We did host it virtually, and it was on YouTube and Facebook Live. And really, it was a wonderful salute to our frontline healthcare workers. We had almost 300 people join online and helped us to raise funds for the COVID Relief Fund. And since that time, we've continued to have people log in, and we've had over 540 views. So I think overall, we really set a high bar for virtual events for this community. And so appreciate everybody who participated or who was able to attend the event. It really was wonderful from that standpoint. The last thing I do want to just say is I want to just mention October Employee of the Month, because it's important that we recognize our employees that have been, some of them have been going, I know almost everybody has been going above and beyond, but we do want to recognize Natalie Servino. She's a buyer in materials management. And basically, the patient-first ethic applies to every area of our hospital, and while staff members working in purchasing may never meet a patient, without their efforts, there would be no supplies or equipment to serve our patients. Natalie was born in Guam when she was 9 years old. Her parents moved to the U.S. to provide opportunities for better education for Natalie and her 4 siblings. After graduating from James Logan High School in Union City and Cal State East Bay, Natalie began thinking about ways she could combine her desire to serve others with career opportunities. Through friends who worked at Washington Hospital, Natalie discovered there are multiple ways to serve hospital patients. She began working in the storeroom delivering supplies. Natalie enjoyed both her coworkers and the fast-paced environment. When a position as a buyer became available in purchasing, Natalie transitioned into the new role seamlessly. She is proud of the work she does and her coworkers and the work that her coworkers do. She says, during this time of COVID-19, though we are not directly caring for patients, we are helping to provide the PPE and other supplies needed. it's nice to feel like we're contributing. And I will say that it's been a very important role in COVID in terms of being able to procure the supplies that we need. And the whole team, including Natalie in purchasing, has done an amazing job. Her coworkers and colleagues in other departments describe Natalie as hardworking, proactive, and always willing to do what it takes to get the job done. Purchasing manager Vincent Caruso describes her as an asset to the team with a fun personality and a strong work ethic. She's the youngest of 5 children. Natalie is the athlete of the family, excelling in volleyball and Brazilian jiu-jitsu. Through each of her siblings has musical talent. She admits when it comes to music, I make a better listener. So she currently lives in Union City with her sister Emily. So we just wanted to let you know about Natalie Servino. So those are my announcements for this evening.
Oh, okay. Well, thank you, Kimberly. Does any board member have anything they'd like to discuss or comment on? Okay, well, there will be no closed session tonight. And so with that, I guess this meeting is adjourned. We'll see you next Monday.
All right.
Good evening. Stay safe.
Thank you. Stay safe.